Hello everyone, this is Dr. Saroj Siddhartha from the platform of UKMLA with DSS. So let's just continue our UKMLA to Success course lecture, and the topic that we are going to discuss today is SIMMAN, and it is one of my favorite topics to teach, and it's a really essential topic because you are going to get a SIMMAN station in your exam. It really happens that they eliminate SIMMAN, but in most of the cases, the SIMMAN station is definitely there. And this can be challenging for multiple reasons because number one, it's an emergency situation. So the main idea behind it is they want to see whether or not you are able to deal with emergency situation, whether or not you are able to uh, deal with the situation that can put you in a panic state. Because the patient over here would be vitally unstable. Most likely, they're going to be vitally unstable, or they may be having a declining level of consciousness, and you would have to assess the patient, identify the condition, and manage the situation accordingly. So it's basically a life-threatening condition, and in 8 minutes, your task is to save the life of the patient. And since this is something an emergency situation, and yes, you need to be quick to react. Yes, you need to be very proactive. But what they want to see that are you panicking? Like, are you doing everything in a hurry? Are you doing everything in a rush? So what misunderstanding a lot of people have is that okay, this is a crash call, this is a crash patient. Okay, in the SIMMAN, the patient is in an emergency situation. Yes, the condition is life threatening. Yes, and the patient is actually very critical. True, but the patient is not dying at the moment right now. Okay, the patient is not going to crash. You do not have to run a CPR. You do not have to run the ACS protocol. Okay, you do not have to attach a defibrillator. Okay, so you don't need to rush. Like I have seen, and when I've taken the mocks of the SIMMAN as well, I've seen the candidates, they're rushing and doing this. Okay, let me just get an ABG. Okay, let me just attach normal saline to you. Okay, let me just quickly attach oxygen to you. You don't need to be in that state. Okay, you don't need to panic, just relax. Okay, the patient is critical. So what they need to see is that your proactive approach and your active approach basically. Okay, and not, they don't want to see you in the panic state. Okay, that you are running here and there, you are dropping the things of your hand. Okay, and you're not doing the IV cannula properly. Okay, do not like create that situation, and do not act in that way, because this is the impression that a lot of people have. Okay, it's semen, the simulator is about to die, I need to panic, I need to rush. You're panicking and you're rushing, and just acting as if that the patient is about to die wouldn't help you. Okay, it wouldn't help save the patient. Whatever you are doing, you need to do it very calmly, very patiently, but in a proactive way. So that is one thing that you need to understand. And a lot of people, they don't understand this, and as a result of which they lose their IPS, and then they keep on forgetting important things of the management and the data gathering as well. So so keep that in mind while you are preparing for SIMMAN, and whenever you are dealing with a SIMMAN case. Other than that, it can get difficult because it is not the typical data gathering and the typical management. There is a separate approach. There is a different approach that you need to take. That is the emergency approach, which is also known as the ABCDE approach. That is the airway, breathing, circulation, disability, and exposure. Okay, so the ABCDE approach needs to be taken, and the assessment and the data gathering needs to be done in that particular order. And you may keep on finding abnormal things and abnormal pathologies in either A, in B, in C, or D, or even E, and then you would have to do the relevant management, and the relevant investigations may have to be ordered on that particular letter only. Like if you feel that the airway is compromised, then you would have to do the intervention for the airway, and intervention to make the airway patent in A only. Okay, so these are the things that you need to keep in your mind. So the data gathering and the management and the intervention, they go hand in hand. Okay, so that is what is a bit different. Other than that, you need to be able to keep on naming the right investigations, and you've got a mark for that as well. And you need to make sure that you name the right investigation at the right time. Like for example, you're not supposed to like order the investigations of D in the C part. Okay, so you need to make sure that you are naming the right investigations at the right letter or at the right level. So that is one thing. Other than that, you're going to see that there is a monitor that would be attached, okay, and constantly you would have to refer to the monitor as well. As you can see over here, there's an ECG rhythm, oxygen saturation, blood pressure, respiratory rate. So you see the vitals are there on the monitor, okay, and then you would have to play with the monitor as well. You would have to see the monitor. You would have to uh, comment on what's the written there, or what's seen in the monitor as well. And the examiner is going to play with you. They're going to drop the oxygen saturation, they're going to drop your blood pressure, they may increase the respiratory rate in case of a respiratory distress case, okay. So you need to take the monitor as well, in hand at the same time. So not just your clinical examination, not just the data that you're trying to gather, not just your assessments, but monitor is also something that you would have to keep an eye on. So you see there are multiple things that you need to do in a SIMMAN station, and the pressure of exam, and then the pressure of the patient being critical and not being vitally stable, okay. That is something that is being tested, and that is getting the best out of you, okay. So it can get a bit complicated. So, despite the fact that you are well aware of the approach, or despite the fact that you have read the Simon stations like really, really well, still you cannot master Simon until unless you have practiced it, until unless you have done it so many times that you are able to control your nerves, and that you are able to have a very well command on your nerves while doing the Simon station, because it's a test of your nerve, it is a test of your patience, and of course, it is the test of your competence as well, that how well you are able to deal with common medical emergencies. Okay. So as I told you that there is an A, B, C, D, E approach. So there are few cases in which the problem may be at A. Like for example, in the case of anaphylaxis, the airway would be compromised. Okay, so the problem would be at the airway level. Then there are a few cases in which the problem would be at B. Like for example, in the asthma case, in the COPD case, in the pneumonia case. Okay, the problem would be with the breathing part. Okay, so you would have to do the most of the interventions in the B part, okay. And then there are a lot of cases in which the problem is at C, or the circulation part. Like for example, there is a case of acute limb ischemia in which there is a blood clot and the patient is not able to feel his leg and is having a severe pain in the leg, okay. Then post-operative hypotension, the blood pressure is falling down, the patient is going into a circulatory into a hypovolemic shock, okay. So again the problem is in C. Then bleeding cases, you may experience, and you may find a lady with postpartum hemorrhage. Then a patient on warfarin may just present to you with rectal bleeding as well, okay. And a patient with gastric ulcers may just present to you with hematemesis, okay. So all of these would be the issues that are related to the circulation part. And then in the D part, the disability part, okay, hypoglycemia, the blood sugars are checked in the D part, okay, and the issues related to the blood sugars are categorized into the D part, okay. So hypoglycemia is something that would happen in D. And then patient with opioid poisoning, they would also need some interventions throughout, but mostly in D, okay. So like each and every level they have something or the other, and there are a few cases in which the problem is there throughout, okay. Like for example, it's a general problem. Like for example, the post-operative pain, okay. The patient of post-operative pain would also be tachypneic. So you would think that okay, it's a problem in the R, in the breathing part, okay. And the patient would also be tachycardic, okay. So you would think that okay, the problem is maybe in the circulation part, okay, but it would be just pain, okay. It would be just a generalized problem, so you just need to manage the post-operative pain, and the patient would automatically become vitally stable. And then collectively, all the parameters A, B, C, and D, all of them are affected in the case of sepsis, okay. So urosepsis case may present to you, in which the patient may have problems in all of them, okay. So the problem can be anywhere, and you need to identify that what is the problem, and then do the relevant investigations, okay. That is investigations and interventions, okay. That is one thing. Another very important thing, let's suppose that the problem is just in A, okay, and the people think that okay, the problem is in A, it's an anaphylaxis case, okay, I'll just stick to A for the next 8 minutes and I'll be good to go. That is incorrect, okay. Once you're done with A, once you've done a particular intervention in the A part, and once you have tried to manage the anaphylaxis by giving intramuscular adrenaline in the A part, then don't just stick at the A part, and then don't just keep on watching the monitor for oxygen saturation and respiratory rate, and then keep on checking your tongue for lip swelling and tongue swelling. Okay, do not just stick to that. Move on. You need to compose the complete the ABCDE approach. Nevertheless, okay, you need to do the complete assessment, even if the problem is just in A or B. Okay, you need to move to C, you need to move to D, you need to move to E as well. Okay, so a lot of people, they just keep it incomplete. Okay, just because they find that there is a problem in A only, and nothing is going to be wrong in C, and they just assume that nothing is going to be wrong in D, or nothing is going to be wrong in B. So they don't just move, they just stick to A part, and they just keep on doing the interventions and the investigations that are related to the A part. And then eventually, even if they've saved the patient, even if they've um, manage that particular medical emergency, they still end up getting maybe 2 or 3 in 3 out of 12 in the cement stations. Okay, so do not make that mistake. You need to move on, and you need to complete your assessment of the ABCDE for every case, for every other case. Okay, it's just the matter of fact that where you need to do the aggressive interventions. Okay, but the approach needs to be completed. All right, so yeah, so now let's just begin, and let's just see what to do and how to go about it in the Simon station. And you need to make sure that you realize whether or not the patient over there is conscious or unconscious. Okay, so there are two possibilities. Either the patient would be conscious, okay, or would be having a declining level of consciousness, but the patient would be responding to you. Number one. Number two, there is a possibility that the patient may be just unconscious, okay, may not be responding to you. Like, for example, in the opioid poisoning case, the patient may be unconscious. In the hypoglycemia case, the patient may be unconscious. Even in the anaphylaxis case, there is a very strong possibility that the patient is unconscious. Okay, so you need to see, and then you need to act accordingly. All right. So let's just go through it one by one. In the Simon, there are some pre-assessments and the prerequisites that you need to make, like before you actually start with the Simon assessment. Okay, before you actually come to the ABCD approach, and this is like really important. Okay, so first of all, you need to introduce yourself. That hello, I am Dr. Siddiqui, one of the FI2 in this acute medical unit. Okay, and then you need to confirm the identity of the patient. Okay, so you got to see if the patient is conscious. Okay, if the patient is conscious, then just directly talk to the patient that okay, are you Mr. Smith? Can you please confirm your age for me? Okay, and that should be enough to confirm the identity of the patient. But let's suppose if the patient is unconscious. Okay, in this case, what you need to do is that you need to go towards the wrist of the patient and check the wristband. Okay, the patients are usually wearing a wristband, okay, in which the identity of the patient is mentioned, the name is mentioned, and the age is mentioned. Okay, so you need to do that before you begin your station. Okay, so it doesn't mean that if a patient is unconscious, you're not going to confirm the identity. Use the wristband to confirm the identity. This is like really important. A lot of people miss this, and then they end up compromising their IPS marks. Okay, and now the repo building needs to be there. Okay, like you can see that okay, the patient is in a distress right now. The patient is trying to fight for his life, and the patient would be in a very panicky situation. Okay, so you need to calm the patient down, you need to reassure the patient, and you need to be having a very supportive tone, because that is something that adds a lot of value to your IPS skills. Okay, and if the patient is conscious, okay, you can just say that okay, I can see that you are in a lot of distress right now, Mr. Adam. Don't worry, I am here. You are in safe hands, and I'll try my best to help you, and I'll try my best to get you out of this situation. I'm going to try my best to manage your condition. Don't worry, Mr. Adam, you will be fine. You're in the safe hands right now. I am here for you. The medical team is here for you. Whatever is bothering you right now, whatever is distressing you right now, we're going to take care of it. Okay, so be supportive. Okay, try to build that kind of a rapport. And if the patient is unconscious, okay, so what is the mistake that a lot of people do? If the patient is unconscious, they don't even talk to the patient. Okay, they're like, the patient is unconscious, he's not going to listen to me anyways, so what I'm just going to do is I'm just going to move on with my assessment. But no, even though if the patient is unconscious, still say all of these things, that okay, Mr. Adam, don't worry, I'm going to help you. You are in safe hands right now, you will be fine. You know that the patient is unconscious, okay, the patient may not be listening to you, but you need to have that reassuring tone, okay. Nevertheless, even if the patient is unconscious, okay, still say the aforementioned line, okay. Really, really important for the rapport building. Do not just ignore it because the patient is unconscious, okay. Keep on, saying that no problem, Mr. Adam, just be a bit louder at this time, okay, because it should give the impression that, okay, you are trying to, wake the patient up, you are trying to, talk to the patient, you are trying to, get the patient back, okay. So instead of, just saying it very nicely that I can see you are in a lot of distress, don't worry, you will be fine and you are in the safe hands right now, be a bit louder. I can see, Mr. Adam, that you are in a lot of distress right now. I know that there is something wrong going with you. Don't worry, you will be fine. You are in the safe hands, okay? I'm trying to help you in the best way I can. Just cooperate with me. Okay, do this. Okay, do this. Okay, even if the patient is unconscious, because this is really important for your rapport building and this is very important for the exam purpose and your IPS. Okay, number three. Okay, now there is a very important tip that I would like to give. A lot of you make this mistake, and nothing new. Even when I was giving my lab, even I made this mistake. That I ended up, and a lot of people, end up talking to the examiner. Okay, what you need to do is that you need to assume that there is no examiner in the room. The examiner doesn't exist. Okay, that is what you need to have in your mind. What a lot of people make the mistake is that, okay, examiner, I am looking at the heart rate in the monitor, it is within the normal range. You need to assume that there is no examiner, you need to directly talk to the patient. Okay, so addressing the examiner that, okay, examiner, I can see that my patient Mr. Adams heart rate is within the normal range, that is the incorrect way to go about it. The correct way is that directly address the patient. Okay, there is no examiner in the room, assume that there is no one in the room, it's just you and the patient. Okay, and you're going to say that, okay, Mr. Adam, I just had a quick look at the monitor and I can see that your heart rate is within the normal limit, so I'm happy with your heart rate. Okay, I'm happy with your oxygen saturation, I'm happy with your vitals. Okay, that is the habit that you need to develop. Whatever you are doing, whatever intervention you are doing, okay, it needs to be addressed to the patient directly, even if the patient is unconscious. Okay, keep on talking to the patient, you are not supposed to talk to the examiner. So don't make two mistakes. Number one, staying silent and not speaking anything. Okay, just doing the intervention, like for example, if you pick up oxygen mask and if you attach it, okay, without saying anything, that is fine, you are still doing the intervention. Okay, so you may get the mark for the management. Okay, but if you're doing it by addressing to the examiner that, okay, examiner, this is an oxygen mask that I am attaching to my patient because his oxygen saturation is a bit low, you may get the mark for the management, but your IPS skills would, go down. Okay, so you need to make sure that, you are covering your IPS as well. And the best way to go about is that, okay, Mr. Adam, I just had a quick look at the monitor, I can see that your oxygen saturation is quite low. I can see that your oxygen saturation is quite low, which means you might be in some kind of a respiratory distress. Let me just attach some oxygen so that you start feeling better. Okay, instead of saying that, okay, examiner, I can see that Mr. Adams' oxygen saturation is a bit low and he is in some respiratory distress. Let me just attach an oxygen mask to Mr. Adam. That is the incorrect way to go about it. Just be direct with the patient. Okay, whether the patient is conscious or unconscious, and that is what is going to earn your marks in your IPS skills. Okay, and they may just, cut some marks in your management skills as well if you're just constantly addressing the examiner and if you're not, directly talking to the patient. Okay, so make sure that, you directly and always involve the patient in the management. Okay, and do not think that the examiner is there and do not keep on talking to the examiner. It's not needed at all until unless it is said in the case notes that after the 6-minute bell, go and talk to the examiner. There are a few cases of SIMMAN in which until 6 minutes you are supposed to just quietly do the interventions and not speak a word. Okay, and then after the 6-minute time, you need to, go to the examiner and then just explain what you noted and what you did. Okay, so this type of, case notes on this type of the variant of the SIMMAN was being tested very initially. Okay, but recently they're not testing it this way, and now they just want you to keep on speaking, keep on verbalizing whatever interventions that you are doing. Okay, so after you have done that, and after you have made sure that you have done the repo building, and after you this thing is there in your head that okay, you don't need to talk to the examiner. Okay, then you need to do the brief data gathering. Okay, so this data gathering is just a very very brief data gathering, and there is a reason why we are asking these particular questions. Okay, and I'm going to talk about it later on once I move on with the lecture. Okay, so you just assess the situation, like the brief OD para, and what might be the situation. The patient, may just be having shortness of breath. The patient may just be having, dizziness. Okay, so you just ask them, okay, since how long you've been having this, or what is this happening, why it happened, since how long has this thing been happening? Have you done anything for it? Okay, so just the what, when, why, and the how of the complaint, or just the brief OD para of the complaint should be more than enough. Okay, and then you need to ask these two questions, like these two questions are like really really important. Number one, do you have any COPD or any smoker's cough? Okay, and then by any chance do you have any vomiting at the moment? Okay, remember these questions. Make sure that you ask them very early on before you begin your ABCDE. Okay, and I'll tell you later on why are these questions important. Okay, and then you can very quickly ask about the PMAP, that is the past medical illness, allergies, and the family history. Okay, very briefly. You should not be spending more than a minute in this. Okay, this is something that is not very important. This is something that is not to be asked in a lot of detail. Okay, just make sure that you briefly touch upon it. Okay, and why these questions, I'm going to talk to you about it later on, and I'm going to tell you why are these things important. Okay, this is this summary of the SIMMAN approach. Okay, I'm going to discuss the summary, and I'm going to discuss the what is written in the other boxes, but what I would like to tell you is focus on these two rows and these columns. Okay, focus on this. This is the approach that you need to follow. Okay, you can see that the SIMMAN assessment tool. Okay, on the first thing is the airway. Okay, and after the airway, once you're in the airway, you need to do the airway assessment. Okay, you need to look at the monitor parameters that are related to the airway. Then you need to do the relevant intervention, and then you need to do the relevant investigations. Okay, so in the airway you need to do one, two, three, four things. Okay, then after the airway, when you move to breathing, okay, then again for the breathing you need to do certain assessments. Then again for the breathing you need to look at the monitors. Okay, for certain parameters. Then you need to do some interventions related to the breathing, and then some investigations. Okay, and now what I want to tell you now, what important thing that I want to teach you. So it is taught, and it is marketed that SIMMAN is an ABCDE approach. It's not the simple ABCDE and E. Okay, there are a few reassessments that needs to be done, and you need to have the practice of doing the reassessment. Okay, a lot of people, they say that doctor, I followed the ABCDE approach, and I did each and everything in the ABCD and E. I still failed the station. I was still not able to manage my patient completely, and I do not understand why it happened. This happened because you did not reassess the patient. You did not know that when to reassess and what are the parameters you need to see while you are reassessing. Okay, so there are total of four reassessments that you need to do. Okay, the first reassessment is after the airway and the breathing. Okay, once you're done with the airway and the breathing, then comes the first reassessment. Okay, and then after you're done with reassessing the airway and the breathing, okay, you need to then move to the circulation part. Okay, and then after you're done with the circulation part, that there is another reassessment. Okay, that is reassessment of the airway and the breathing. So the first one was the reassessment of the airway. Okay, not the breathing. Why? Because you just did the breathing part. Okay, In the second one, you need to assess the airway and the breathing, okay, not the circulation. Why? Because you just reassess the circulation part, and then after the second reassessment, you move on to the D part, okay. And then after you're done with the D part, what you're going to do is that you're going to do your third reassessment, okay, that is a reassessment of the airway, breathing and circulation, okay. And then after you're done with that, then you move on to the E part, okay. And in the end, once you're done with your entire A, B, C, D and E, then you do the fourth reassessment, in which you reassess all the things: airway, breathing, circulation and disability, okay. So a lot of people do not have the habit of going back and see whether or not they have the intervention that they have done, whether or not it's acting or not, whether or not it has worked or not. And I'll just share an example with you. Like for example, if it is in asthma case, okay, in the asthma case, the patient will have shortness of breath, okay. So you started off with your prerequisites, and you did the rapport building, and then you ask about you did the data gathering and all, and then you assess the airway, okay. The airway was completely fine. You looked at the monitor, and the oxygen saturation, the respiratory rate was D-range, saturation was low, respiratory rate was high, okay. And then you did the possible intervention. There was no intervention in the airway because there was no problem with the airway, okay. So you directly move on to the breathing, and once you started the breathing, okay, you did the assessment, you checked the oxygen saturation, respiratory rate, and you during the assessment, you found out that there was bilateral wheezes that were present, and immediately in the breathing part, you knew that okay, this is asthma, okay. So what you did was that you give the bronchodilators, okay. You did the bronchodilators, okay. That is the salbutamol that you gave, and you immediately moved on to C, okay. And then you started doing the assessment, intervention, monitor, and the investigations of the C part, okay. And what you did, you did not reassess, you did not check the monitor for the oxygen saturation and the respiratory rate again, and then you eventually moved on to D, okay, without checking the oxygen saturation and the respiratory rate. And while you moved on to D, what the examiner did, they basically dropped the oxygen saturation again, okay. And you were so just adamant on the fact that okay, you just need to complete the ABCDE approach. You never looked at the oxygen saturation, the respiratory rate again after just giving salbutamol, okay. And the oxygen saturation kept on dropping, and you were just assessing the circulation, you were just checking the blood sugars, okay. You were just checking the blood pressure and the heart rate, okay, and all the parameters of the C and D part, okay. You completely forgot about it. Why? Because you did not reassess, you did not see whether or not the bronchodilator that you gave, you did not assess whether or not the salbutamol that you gave has it done its part or not, okay. And the oxygen and the examiner would be dropping your saturation, okay. They would not stabilize the patient until you have taken the next step of the asthma management, okay. So in the breathing part, you gave bronchodilator, okay, and then you reassessed, it was fine until that. After the circulation part, once you reassess on this part, there's reassessment number 2, okay, you would find that okay, the oxygen saturation is again low, okay. And what does this say? That during the reassessment, you need to do the relevant interventions, okay. So now you have given salbutamol, so the next intervention would be ipratropium, okay. So that is what you need to do in the second reassessment, okay. So you gave ipratropium, the oxygen saturation started to improve again, and then you move on to D, okay. Then after you have done D, you did the third reassessment, and then you find out that the oxygen saturation was still low, okay. And now you need to do the relevant intervention again. So after ipratropium, you gave 250 mg or 100 mg of hydrocortisone, okay. And then again the oxygen saturation of the patient improved, okay. So you moved on to exposure and escalation, okay. And then once you're done with the exposure, you check the skin rashes, and did the assessment and the interventions, okay. And then you again reassessed, and you saw that again the oxygen saturation is still low, okay. And now you need to give magnesium sulfate and call the seniors for a possible intubation, okay. So you see, the even though the problem was at B, okay, in the asthma case the problem was at the B level, but not all the interventions was done at B. You did one intervention at B, the other intervention was done after C, The next intervention was done after D, and the next intervention was done after E. And the only reason why you were able to do it because you were reassessing. And just think about the case where you did not reassess. Okay, you did not reassess, and you just, after the B you went to C, and then right after C you did not reassess and you went on to D, and then after D you did not reassess and then you went on to E. By the time you completed your A, B, C, D and E protocol, the oxygen saturation would have been in 60s. Okay, and despite all your effort, okay, even if you started giving ipratropium, hydrocortisone, and magnesium sulfate, all of it together in the after the E part, okay, the oxygen saturation of the patient wouldn't have improved. Okay, and eventually the patient would have died. Okay, so now after the exam you would come to me and come to any tutor who you are following, that okay, Dr. Siddiqui, I followed the ABCD approach. I did the airway, I did the breathing, I did give salbutamol in the B part because it was a breathing related issue, and then I did the C and did the E as well, and then I did each and everything. I asked about the data gathering questions, and then later on I gave ipratropium, magnesium sulfate, hydrocortisone, and I eventually intubated the patient as well. Why did I fail the station? Because you did not reassess the patient at the right time, because you did not do the right investigation at the right time, the right intervention at the right time. Okay, so it's not about doing the relevant interventions like all at once. It needs to be done at the right time as well. Okay, that is like really really important. So right intervention, right investigation, right assessment at the right time and at the right level. And you need to have this reassessment approach. Okay, and without this reassessment approach, trust me on this, you would not be able to like manage the semen properly. And I just gave you an example of the asthma case, and similarly for every other case, for the anaphylaxis case, you have to give intramuscular adrenaline. Okay, so that is a problem in the airway. So once you notice that, okay, you did the intervention in the airway, and later on you have to repeat IM adrenaline 2 more times. Okay, and if you do not reassess, you wouldn't realize that okay, the saturation has not improved, the respiratory rate has not improved. Okay, and if you don't realize that, you would not be naturally repeating adrenaline. Okay, and you would never know that okay, you have to repeat ad again. Okay, you would be just examining the chest, you would be just assessing the circulation, you would be just checking the blood sugars and checking for bleeding and skin rashes, and your session would be over and the patient's anaphylaxis would not be sorted. Why? Because you did not reassess. Okay, opioid poisoning, naloxone needs to be repeated at least 4 times. Okay, in different doses. Okay, and again, if you're not reassessing, you would not be able to identify that. Okay, same goes for the bleeding problems. Okay, initially you need to give fluids, and then you need to give reversals of vitamin K, and then you would have to reversal of the warfarin, that is vitamin K, and you may have to transfuse blood as well. So there are multiple steps of the management, and all of them need not to be done all at once. Okay, you need to take a step by step approach. A lot of interventions are done at the reassessment part. Okay, just the first step is done at that particular part that is related to the problem. Okay, and the other interventions are done on the reassessment part. So always have the habit of reassessment. Okay, really important. All right, so yeah, this is the reassessment art that I wanted to teach, and this is the 4 components of every parameter and every protocol of the ABCDE that I wanted to discuss, which is the assessment, monitoring, intervention and investigations. And now let's just go through the SIMMAN approach one by one, and what we are going to do is we're going to take it one letter at a time. Okay, so the SIMMAN approach is the airway first. Okay, and in the airway, the assessment. Now, what is the assessment in the airway? The assessment in the airway is that number one, if the patient is speaking, okay, you need to assume that the airway is patent. Okay, because if the airway was not patent, if there was any problem with the airway, the patient wouldn't have been speaking. Okay, so if the patient is conscious and responding to you, okay, then you can very safely say that okay, since my patient is speaking, I can assume that his airway is patent. Okay, but if the patient is unconscious, then you need to check the airway by asking the patient if they can hear you. Okay, so you're going to go very close to the semen and you're going to tap the shoulders and you're going to say that, okay, Mr. Adam, can you hear me? Mr. Adam, can you hear me? Can you open your mouth for me? and of course the patient would be unconscious, so the patient would not be following your command. So what you need to do is you need to open the mouth like this, okay, and you need to just check for the tongue and the lip swelling, because these are the two possible airway obstruction that you may encounter in the PLAP 2. Okay. And very very important thing, if you note that okay there is a tongue and the lip swelling, okay, in an unconscious patient, that means that there is an anaphylaxis going on. Okay, so what you need to do is that you need to check and remove any source that may be causing anaphylaxis. Like for example, you might be seeing that okay there is a antibiotic that is attached, or the patient would be having a blood transfusion, so you need to keep an eye around. Okay, you need to check the drip poles that may be attached to the patient. Okay, and if there is any antibiotic, any blood transfusion that may be going on, so try to stop the source as soon as you noted that there is a tongue swelling and a lip swelling, and you think that there might be some anaphylaxis that might be going on. Okay, so that is in the assessment part. Then you move on to the monitor, and what do you check in the monitor? Oxygen saturation and the respiratory rate. These are the two things that you check in the monitor. Now regarding this, I'm going to teach you different monitor parameters that you need to see in different aspects, either the airway, breathing, circulation, and disability. Okay, and you just need to keep an eye for that particular parameter only. Okay, if the airway monitoring states that you just need to look at the oxygen saturation and the respiratory rate, then do not look at the heart rate, do not look at the ECG rhythm, do not look at the blood pressure. Okay, do not look at the temperature. Why am I saying this? Because this is just going to confuse you. Okay, high heart rate, low blood pressure at the airway level is not your problem. Okay, what you are concerned about is the oxygen saturation and the respiratory rate. And why am I saying this? Because there is a very strong possibility that when you look at the monitor, okay, you may find the oxygen saturation and the respiratory rate to be normal. Okay, and you may see that the blood pressure is like really really low, and then all of a sudden you would panic, and your mind would take you to the circulation part. Okay, and then you'll completely forget about the airway interventions and the airway assessments, and then you would completely forget about the breathing assessment and the intervention that you need to do on the breathing. Okay, then you would completely forget about the reassessment as well, and then you would directly just move on to the circulation part and pick up a normal saline or pick up a fluid and then directly attach it. Okay, so that is why I am saying whatever is there on the monitor, do not give your attention to that. If you're at the airway, your only concern is oxygen saturation and respiratory rate. Okay, all of the parameters, even if they're extremely deranged, you just need to ignore it. Okay, just ignore it. Okay, so now you're going to have a look that okay, if there is a problem with the airway, the oxygen saturation may be low and the respiratory rate may be high, as I've shown it in the monitor over here. Okay, and if it is normal and if there is no problem with the airway or the breathing, then these two parameters would be normal. Okay, then comes the intervention of the airway part. Okay, if you find that the oxygen saturation and the respiratory rate is low, okay, of course you need to start with the oxygen therapy. Okay, and the oxygen therapy really depends on how you give it. Okay, and what are the oxygen flow devices that you are using. Okay, and this is like really really important piece of knowledge that I would like to share with you. Now if you see that the oxygen saturation is low but it is more than 88, okay, then you can just attach a face mask. Okay, so you have to verbalize this thing. Okay, that okay, I'm going to attach a face mask, or I'm going to give you oxygen through a face mask, which would deliver you oxygen at a rate of 6 liter per minute. Okay, and while you are verbalizing it, there would be an emergency crash trolley that would be like placed in the SIMMAN room. Okay, I am not really sure if I have the picture of it. No, I do not have a picture of it over here, but yeah, so there would be, yeah, I have a picture of it. Yeah, so there would be a crash trolley like this that would be placed. Okay, so you need to open one of the drawers, okay, and like actually pick up the face mask and attach it to the SIMMAN's face. Okay, like this. Okay, this is the SIMMAN's face. You have to place it over here, and at the same time you would have to verbalize it as well, that like I'm going to attach a face mask that is going to provide you oxygen at 6 liter per minute. Okay, if the oxygen saturation is less than 88, okay, so this was more than 88, Okay, if it is found to be less than 88, okay, then what you need to do is that you're going to give the oxygen through the rebreather mask, okay, that is having a flow rate of 15 liter per minute, okay, at 100% oxygen. Okay, so you need to see if the oxygen saturation is way less than 88, okay, then the rebreather mask would be given. And if the oxygen saturation is low but not less than 88, then you can give the face mask, okay. And you need to know the flow rate as well, okay. Now, very, very important. Remember, I asked you to, keep these two questions in mind. That do you have any COPD or smoker's cough, and do you have any vomiting? Okay, why did I, like made you ask these two questions? Because if the patient is having any hematemesis or any vomiting, okay, you cannot attach a face mask, or you not attach a mask on the face of the patient. Why? Because if the patient is having any hematemesis, okay, or if the patient is having any vomiting, there is a very strong possibility that the vomit may just accumulate in the mask. It can prevent oxygen delivery, number one, and number two, it increases the risk of aspiration as well. Okay, just think, the vomit is not going out, it is being stayed at the mouth level inside a mask, and the patient would eventually swallow the vomit content and eventually aspirate it. So a critical patient can get more critical and can eventually die as well, okay. So the patient who is having hematemesis, okay, you are supposed to give the oxygen delivery through a nasal cannula, okay, and the flow rate of the nasal cannula is 4 liter per minute, okay. So that is why asking about the vomiting is very, very important. By any chance, are you having any vomiting? And if the patient says, yes doctor, I've been constantly vomiting blood, you immediately know that this is a hematemesis case, okay, and this is a gastric ulcer that is bleeding in the patient, okay, and you cannot oxygenate the patient with the entire mask that is covering his entire face, okay. Really, really important. And then you gotta see that if the patient has any COPD or not. Remember, we asked this question as well, that by any chance, do you have any COPD or smoker's cough? Why? Because we all know that in a COPD patient, you need to have a controlled oxygen flow rate on oxygen delivery, and you need to give it through the Venturi mask, okay. So you need to ask this thing, okay, if you have any COPD, then what we are going to do is that we are going to give you the oxygen through the Venturi mask, and the rate is also 4 liter per minute, but 100% oxygen would not be delivered. You would be delivering 24 to 28% oxygen, okay. So you need to see that what type of case it is, and what type of oxygen delivery device you need to use, okay. And this is how it looks, okay. The nasal cannula, the nasal prong looks like this: simple face mask, a non rebreather mask, partial rebreather mask, okay, depending on saturation and the case to case. And then the Venturi mask, okay. These are the Venturi devices that you may need, and you may need to apply, and it depends on color to color which color device you would need to deliver a certain percentage of oxygen, okay. So the ideal is 24 to 28% in a patient of COPD, okay. So this intervention and this oxygen therapy is really, really important. A lot of people, they say, doctor, I attached the oxygen, but my friend, you did not attach the oxygen in the right way. You did not use the right mask. You did not use the right flow rate. You did not use the correct oxygen percentage, 100%, 24%, 28%. Okay, so all of these things are like really, really important. Okay, and you need to master the oxygen therapy. You need to have this thing very clear in your head. Other than oxygen, there may be, if it's a case of anaphylaxis, okay, you would have to give intramuscular add 1 in 1000 0.5 ml, okay. And you need to remember this, and you need to know this. I'll tell you why. Because a lot of candidates, what mistake they make is that they eventually end up saying that I would like to give you intravenous adrenaline. Okay, it's not intravenous, okay. IV ad is given to those patients who are under cardiac arrest, and you are giving a CPR to the patient, okay. Or in those cases, you give IV epinephrine and IV adrenaline, okay. So make sure that you use the right route, okay, intravenous, okay. Then you use the right concentration, that is 1 in 1000, Okay, a lot of people say 1 in 100, 1 in 10,000. No, it's 1 in 1,000 and zero point 0.5 ml. Okay, that can be repeated twice. All right, so you need to be aware of these doses. You need to be aware of the drugs. Okay, the right route, the right name of the drug, the right concentration. Okay, and the right dose. Okay, all of it needs to be there in your mind, and you need to verbalize it correctly. Okay, not just verbalize it, you would have to eventually go to the emergency crash trolley. Okay, and you can see that there are a lot of medications, everything is present in the emergency crash cart. Okay, you have to pick up the adrenaline 1 in 1,000 0.5 ml, and then you also need to pick up a small syringe. Okay, and then act as if you are administering the adrenaline. Okay, and verbalize it at the same time, that okay, let me just attach the, or let me just administer zero point 0.5 ml of adrenaline 1 in 1,000 intramuscularly. Okay, that is the right way to go about the intervention. Okay, and the investigations, there are not a lot of investigations that you need to do at airway level, unless it's the anaphylaxis case, in which you may have to just order serum tryptase. Okay, but that is just the one investigation that you need to do, and specifically in the anaphylaxis case. If it's a case other than anaphylaxis, and if all the parameters are normal, or if it's indicating towards some other pathology other than anaphylaxis, then you don't need to name any investigation. Okay, so that completes the A part. Okay, now let's move on to the breathing part. In the breathing, the assessment is basically chest examination. Okay, and very important IPS pointer. Okay, I'm going to highlight the IPS pointer in blue. Before you start off with examining the patient's chest. Okay, you need to explain that, okay, Mr. Adam, I would have to examine you. For the purpose of it, I would have to expose your chest, and I would I would have to touch you, and I would have to feel your skin as well, and I would also use my stethoscope to auscultate and listen to what's going inside you. In order to maintain your privacy and dignity, we are going to make sure that we do it in the most decent way possible. And I will also have one of my medical team members to act as a chaperone, and I will take all the universal precautions. Can I please proceed with the examination? Okay, so you gotta say this, you gotta verbalize this, that okay, explain the procedure, what you're going to do. You would have to touch the patient, you would have to feel the patient, you would have to use your stethoscope on the patient. Okay, you would have to offer a chaperone. So there would be another person in the room who would be acting as a chaperone. You'll try to maintain the dignity and the privacy of the patient as well. And you need to tell that I have taken all the universal precautions. The universal precaution basically means that you have washed your hands, you are wearing your gloves, you are wearing your gown. Okay, so you need to verbalize all of these things. Okay, these are like really important IPS pointers. A lot of candidates are so much stressed, and they have so much exam anxiety, and they're like, my time is running. They just go out there and open the chest, and they just started percussing and palpating. Okay, that is not the right way to go about it. And then in the assessment, you check the trachea position. Okay, you're going to like hold the trachea like this, and you're going to say that, okay, let me just check your windpipe. Okay, and then you're going to hold the patient like this and ask them to breathe, and check the chest expansion, and then you're going to do the percussion. Okay, so till here it's just acting. Okay, like just doing it for the sake of doing it. But once you auscultate the chest, okay, this is where you're going to get the findings. Okay, this is where you're going to get the stuff. Okay, and what are the findings that you may get? Number one, you may just get wheezes in case of COPD and asthma. You may get crackles, bilateral crackle in the lower zone. In case of heart failure, you may get harsh vesicular breathing. Okay, or crepitations in case of pneumonia. Okay, so you need to make sure that you are well aware of these sounds. Okay, you need to make sure that how the wheeze is heard, how the crackles are heard, and how a harsh vesicular breathing sound is heard. Okay, upon auscultation, if you have got that much clinical experience, and if you've worked in the A&E, and if you've worked in the ICU, then this would not be a problem for you. But if you do not have that much clinical experience, then I would like you to go to YouTube and try to listen to the sounds of the wheezes, crackles and harsh vesicular breathing, so that your brain can understand, okay, this is a wheeze, this is a crackle, and this is a harsh vesicular breathing. Because you would be able, you would have to diagnose the wheezes, and diagnose the crackles, and diagnose the harsh vesicular breathing through auscultation only. Okay, it needs to be done in the auscultation part. If you are not able to auscultate it properly, you're going to miss the V's, and you're never going to come to the diagnosis of asthma and COPD. If you miss the crackles, you're never going to come to the diagnosis of heart failure. And if you miss the harsh vesicular breathing, you may just come to the diagnosis of pneumonia because of the fever, tachycardia and tachypnea. But again, it would get very, very difficult for you. And if you do not appreciate it, okay, of course, your marks would be penalized on it. So make sure that you are aware of it. And then another IPS pointer: do not forget to cover the patient. A lot of people, what mistake that they do is that they completely forget to cover the patient after they have exposed the chest, because they're in so much hurry that they want to complete the station. Their time is running, the patient is dying, we are not going to cover the patient. Okay, do not make this mistake. Okay, it's a very important IPS pointer. If you're not covering the patient, you may just get a 0 in the IPS, even though you are at your best behavior, even though you are very supportive, even though you have tried to be very, very helpful to the patient as well, you've even saved the patient. But if you're not covering the patient, you're going to get a 0 in your IPS. Okay, so make sure that you cover the patient after you're done with the assessment part. Then in the monitor part, again, oxygen saturation and respiratory rate are the two parameters that you need to see. And the intervention, it's the oxygen therapy. Okay, and if it's an asthma or if it's COPD, you may have to do the intervention of asthma, that is salbutamol. Okay, 5 milligram, that can be repeated twice. Okay, then ipratropium 0.5 mg. Okay, then it is followed by IV hydrocortisone 100 milligram. Okay, and then if it doesn't improve, then IV magnesium sulfate. And if it doesn't improve after that as well, then you need to call the intubation team. Okay, so this is the management of asthma, and this is the management of COPD. Okay, so all of these interventions you may have to do in steps. Okay, not all of them together. Okay, I have mentioned it together so for the purpose of teaching, so that you are aware that okay, what are the possible interventions you may have to do, and what are the doses. Okay, salbutamol is 5 mg. Do not say 0.5 mg salbutamol. Okay, that would be incorrect. Okay, and ipratropium is 0.5 mg. Both of them are given as inhalation. Okay, and then the investigations. What are the investigations you need to do in the B part? Okay, so the chest X-ray and ABG, these are the two investigations that you need to do always, despite the case, whatever the case is. Okay, the 10 to 12 cases of SIMMAN that I just talked about. No matter what the case is, the chest X-ray and the ABG have to be ordered at B. Okay, a lot of people forget about it, and then eventually when they are at B and they're at E, and then they're like, oh, I did not order the chest X-ray, oh, I did not order the ABG, and then later on they end up ordering it. But unfortunately the time is gone to order the chest X-ray and EBG, and even if you order it, you may not get the mark, and you may not score for your chest X-ray and your EBG. Okay, and additionally, if it's an asthma case, you may just want to do the spirometry. Okay, so just keep that in mind, that spirometry may be investigation that you may have to order. Okay, but the take home point is chest X-ray and ABG needs to be ordered at B. And then the reassessment. Now before moving on to C, reassess A. Okay, that is the airway. And what is the reassessment? Reassessment is nothing. Okay, you don't need to just again go and open the mouth and again ask that Adam, can you hear me, can you please open your mouth for me? No, the reassessment part is only checking the monitor. Okay, the monitor parameter of the particular letter that you are at. Okay, so the first reassessment is basically assessing A part. Okay, so you just got to see that what is the monitor aspect of A. Okay, the monitor aspect of A is oxygen saturation respiratory rate. Okay, so you just keep an eye on the oxygen saturation respiratory rate. okay, and you see if there is a need to do any intervention, you do that intervention. Or if everything is all right, okay, and if you've just given salbutamol, of course the oxygen saturation, the respiratory rate would have improved, okay, and you wouldn't have to do a lot of intervention over here. So you just move on to the next part. But if you feel that the oxygen saturation haven't improved with salbutamol in case of asthma, or the oxygen saturation have not improved, after you have given the adrenaline over here in the A, okay, then before moving on to C, you would have to repeat this adrenaline over here, okay, as it is mentioned that it can be repeated twice, okay. So you may just have to repeat it on the reassessment part. Okay, so you need to keep an eye for that, and you need to make sure that you like see whether or not an intervention is needed. And if an intervention is needed, do not move on to C until you have done that particular intervention. All right, now let's suppose that it's everything is okay, and now you have the heads up for going to the C part. Okay, now what you need to do in C, the assessment in the C part is basically number one, you need to assess the capillary refill time. Okay, that is a very important indicator of the circulation. Okay, it is increased in cases of shock as well. Okay, so what you need to do and how you need to do that, you're going to pinch the finger for 5 seconds and you're going to verbalize it. Okay, Mr. Adam, I'm going to pinch your finger for 5 seconds to see how the blood flow is. Okay, and then this is how you're going to check the capillary refill time, number one. Number two, you got to check all the pulses. Okay, and this is like really really important, all the pulses. Okay, why? Because a lot of candidates, what mistake that they do is that they just check the radial pulse and they're like, okay, fine, the pulse is fine, your heart rate is completely fine. But no, you need to check all the pulses, which means you need to check the brachial pulse, you need to check the radial pulse, you need to check the femoral pulse, you need to check the popliteal pulse, you need to check the dorsalis pedis pulse as well. And why am I saying this? Because think about the case of acute limb ischemia. In the acute limb ischemia, if the lower limb is gone, the brachial pulse would be completely fine. The radial pulse would also be fine. And there is a possibility that the femoral pulse would also be fine. But the popliteal, you may not feel the popliteal pulse over there because of the acute limb ischemia. Okay. So try to make the habit and try to, make sure that you are assessing every pulse. You're assessing each and every pulse. Okay. Very, very important. And then once you're done with assessing the pulse, okay, so it's a mannequin, right? It's a mannequin, but it's a very advanced mannequin. Okay, whenever you touch the pulse, okay, whenever you touch the artery that is like there in the mannequin, the GMC do have a device, okay, which basically shows that if the pulses or if the vessels are actually being pressed, okay, and it gets seen in the computer, and it gets seen in the software that okay, the person is actually pressing on the blood vessel. Okay, so you cannot just act and you cannot just just touch and tap the wrist and say that okay, I've done the radial pulse. No, you would actually have to hold it and press it and actually feel the pulse. Okay, so even though it's a mannequin, if even though it's a simulator, but it's a very advanced simulator, and the pulse would be there, you would be able to feel the pulse, and they can even control the pulse. They can in a tachycardic patient they can increase the pulse rate, and in a bradycardic patient they can make the pulse very very weak as well. Okay, so touch all the pulses, okay, and you would be able to actually feel it on the mannequin as well. Each and every pulse would be able to be felt. Okay, so brachial, radial, femoral, popliteal, and dorsalis pedis. Okay, all of the pulses needs to be checked. Then the next thing is basically checking for the peripheries for cold temperature, okay, or for a hot temperature as well, or for the fever as well. And then you need to just check for the visible bleeding signs, that if the patient is bleeding or not. Okay, so these are the 4 assessment pointers. All of it needs to be done. All of it needs to be done correctly. If you miss out on any one of them, your marks would be penalized. Okay, so the margin of error is like again really really low, really really low. Okay, so make sure that you are covering all these 4 things. Okay, all these 4 pointers are like being covered over here. Okay, then the monitor. Okay, now what you need to see in the monitor? Okay, you need to see the heart rate, blood pressure, temperature and the ECG as well. Okay, so now in the monitoring part, there is a lot of things that you need to see, and it's like really important that you see and you comment on each on everything of them. That okay, Mr. Adam, I can see that your heart rate is a bit high, and I can also see that your blood pressure is also a bit low, and at the same time I can see that there is some problem with your heart rhythm that is pointing me towards a pathology called atrial fibrillation. Okay, so whatever you are seeing in the monitor, verbalize it. Okay, I can see that your heart rate is a bit high. Okay, there might be something wrong in your circulation. Okay, I can see that your blood pressure is also very low. Okay, so you may be bleeding from somewhere. Okay, and I can see that your ECG is not normal, so that means your heart is not delivering a correct rhythm. Okay, so appreciate all of these things. And why have I underlined the ECG part? Because a lot of candidates, we miss the ECG. Okay, and there may be a case of acute limb ischemia in which you would be managing the patient, and you would correct the acute limb ischemia as well, and you would give heparin, and you would order Doppler ultrasound, you would order the CT angiogram, you're going to involve the vascular surgeons as well, but still the patient would die. Why? Because you never commented on the ECG, you never had the eye for the ECG. Okay, and as you can see, just look at the rhythm over here. Is it a normal sinus rhythm? No, it is not. It is an atrial fibrillation. The QRS complexes are not regular. Okay, this is an atrial fibrillation. So the acute limb ischemia would not kill the patient. Okay, you have saved the patient because of this acute limb ischemia. You have saved the limb as well. You have given the unfractionated heparin at the right time. Okay, you have involved the vascular surgeons. Okay, you have done the CT angiogram, you have done the Doppler ultrasound, you've done whatever you could have done for the acute limb ischemia, but you never commented on the ECG. And the patient just passed away because of the atrial fibrillation. He developed a stroke, and damn, the patient is gone. Okay, so you need to keep an eye for the ECG as well in the C part. Okay, have a look at the ECG, check the heart rate, check the blood pressure, check the temperature as well. A lot of people miss out on the temperature. It's not seen here in the monitor right now. I've not attached it in the monitor, but it's usually there in the GMC monitor. The temperature is usually present, so go and have a look at the temperature as well, because the heart rate would be high, the blood pressure would be low, the respiratory rate would also be high, the oxygen saturation would be low, and you're only able to come to the idea that okay, this is a sepsis case by looking at the temperature. The temperature would also be high, and the sepsis case is the only case in plateau where the temperature is high, and if you see that the temperature is high, you eventually know that okay, this is a sepsis case. Okay, so always keep an eye for all these parameters. Okay, you're not supposed to miss out on any of these. All right, then the intervention, really important. Okay, you need to make sure that you do this intervention in all the cases. Okay, despite whatever the case is. Okay, you need to make sure that you take two large IV cannulas. Okay, and you need to verbalize this thing that okay, Mr. Adam, let me just take two large IV cannulas and take some blood samples to send your investigations, to send your blood sample investigations, and just to group and save in case you need blood transfusion. Okay, you need to do this in all the cases. Okay, because every case you would require some intervention or the other, you would have to send some investigation or the other. Okay, so you need to make sure that you are taking two large IV cannulas, because a lot of investigation and a lot of intervention needs to be done through these cannulas. Okay, and once you say that you are taking large cannulas, okay, you need to pick up the right color. Okay, like for example, if you want a larger gauge cannula, if you want to give hydration, and if you want to make sure that you give the ample amount of fluid, then pick up the red one. Okay, or the gray one. Okay, so do not pick the smaller ones like the 24 gauge cannula. It's for the pediatric groups, and it doesn't give you very good flow. Okay, so always make sure that you pick the correct color. Okay, the red one or the gray ones. Okay, and not the smaller ones. And then in the circulation part, you may have to do a lot of interventions. Okay, and I'm going to just talk about the interventions. If the patient is in shock, then you may have to give intravenous normal saline 0.9% 500 ml in 15 minutes. So you need to be aware of these things. You need to know the correct dose, the correct rate, okay, the correct concentration, okay. So you need to say that IV normal saline 0.9% 500 ml, that would be given to you in 15 minutes, Mr. Adam, and that should help you improve your blood pressure, okay. If the patient is bleeding, then you need to say that I would like to give you intravenous tranexamic acid 1 gram stat, okay. If the patient is having any bleeding because of warfarin, okay, then you need to say that okay, let me just give you intravenous vitamin K 3.5 milligrams stat, okay. Then the patient of hematemesis, okay, you may want to give telepressin, that is intravenous 2 milligrams stat, okay. And very important thing, this is a very important point that I would like to share right now. In the cases of circulation, there is a possibility, yes, the patient would be bleeding in the postpartum hemorrhage case, in the vitamin in the warfarin toxicity case, okay, or in the hematemesis case, okay. So at the circulation level, what you need to verbalize is that I need to activate the massive hemorrhagic protocol. Okay, that okay, Mr. Adam, I want to activate the massive hemorrhagic protocol. For that, I would need PTC, that is the prothrombin complex, FFP, that is the fresh frozen plasma, and I would need 6 units of O negative blood, okay. So you would not find the blood product, okay, in the emergency crash trolley. You would not find it in the emergency crash cart, okay. You need to activate the massive hemorrhagic protocol first, okay. And over there the examiner would say that the massive hemorrhage protocol is activated, the blood units are on their way, okay. And you need to continue with your like other interventions and investigations while the blood products are on their way, because if you just order blood, the blood is not available right then and there, okay. It takes some time to get the blood and then get it to the room temperature, okay. So you would just have to continue with your interventions, your investigations, your the ABCDE protocol, okay. And then later on, once you're done with everything, once you've crossed the C part, okay, then the examiner would hand over the blood product to you, that okay, here is the blood product and now you can transfuse the blood, okay. So once you've got the blood, you need to make sure that you start transfusing the blood at a rate of 2 ml per minute, okay. You need to verbalize this thing that okay, since you are bleeding and since you have lost a lot of blood, Mr. Adam, I would like to start the transfusion after making sure that I have checked the blood, that it is free from any infectious disease, it is free from any microorganism, and the screening and the testing is completed, and I have checked that okay, this is an O negative blood, and if it is safe to transfuse and it is at the right temperature. Now what I am going to do is that I am going to begin the transfusion at a rate of 2 ml per minute, okay. You need to be aware of this particular transfusion rate, okay. Then in the heart failure patient case, okay, you may have to give intravenous furosemide 40 mg or 50 mg, okay. Then the chlorpheniramine, you need to give it in anaphylaxis case for itching and for rashes, okay. In the postpartum hemorrhage case, you may have to give intravenous oxytocin 10 international unit, okay. And then in the postpartum hemorrhage case, you may have to do the intervention of doing the uterine massage, and when it comes to the acute limb ischemia, you may have to give intravenous unfractionated heparin 5000 international unit stat, okay. Really important, do not say intramuscular heparin, number one. Do not say the low molecular weight heparin. In the acute limb ischemia, you give UFH, which is the unfractionated heparin 5000 international unit, okay. And it is given IV, not IM. A lot of people just end up giving it intramuscularly, and then they're like, doctor, we just gave a heparin, but why did we fail? Because you gave it IM, okay. And then somebody may just give low molecular weight heparin and then expect to get the ALI sorted, okay. So that is the wrong approach. Make sure that you give unfractionated heparin and not the low molecular weight heparin, okay. Then IV bisoprolol, it may be given to the patients of atrial fibrillation, but you need to make sure that the patient is vitally stable, the blood pressure is not very low, and then only you can give bisoprolol. But if you feel that the blood pressure is also low, okay, and the patient is not vitally stable, and if, let's suppose, if the patient has some asthma or something, okay, then the other option of managing atrial fibrillation is deltaism, okay. Then the patient of SVT, you may want to give IV adenosine, that can be repeated by 6 mg, 12 mg, and 18 mg. Then digoxin is given in patients of atrial fibrillation with heart failure. Okay. Then omeprazole, patient of hematemesis having gastric ulcers and bleeding because of that. You may want to give omeprazole 40 mg IV. And then the opioid poisoning case, okay. In the opioid poisoning case, you're going to see that the pupils are dilated, there's not something wrong with the pupil, and then the respiratory rate is very very low, the pupils are fixed, and the dose for the naloxone that you need to give is 400 microgram initially, followed by 800 microgram, and then again 800 microgram. Okay, so step by step, you're going to give the reversal: 400, 800, 800, okay. And say microgram, okay, this is not milligram, this is a microgram, okay. Then IV paracetamol, may be needed for the patients of sepsis. So 1 gram of IV paracetamol needs to be given, and IV antibiotics needs to be started in the patients of sepsis again, okay. You would have to start the IV antibiotics, and you're going to say that I'm going to start the IV antibiotics as per the trust protocol, okay. So these are the like possible interventions that you would have to do and see, and I've discussed all of them, I've just shared all of them, okay. It depends on case to case that what type of medication you would have to give. I've also mentioned the doses, I've also mentioned the route of the route of the drug administration, okay. So you need to make sure that you are verbalizing the correct dose, the correct drug, and the correct route as well, okay. So yeah, all of these things you need to have in your mind. And now let's just move on to the investigations, okay. So there are a lot of investigation that you may have to order, but the two investigation that are constant in all cases that you need to order in the circulation part or the C part is basically the ECG, the full blood count, or the routine bloods, okay. That is something that you need to verbalize throughout, okay. Like for every SIMMAN station, the ECG and the full blood count and the routine blood needs to be named, okay. Then you may want to name some specific investigations depending on case to case. Like for example, in the case of heart failure, you may want to name an echocardiogram. For acute limb ischemia, you may just want to uh, like order Doppler ultrasound, CT angiogram. For hematemesis case, you may want to go for endoscopy. For postpartum hemorrhage case, you may want to go for the transvaginal ultrasound, okay. For every bleeding cases, you may want to go for blood grouping and clotting profile and INR, specifically in the case of warfarin toxicity and the patient who is bleeding because of uh, the warfarin toxicity, okay. And then for the heart failure cases, you may want to do drop I, and you may want to send the pro BNP. And for the sepsis case, you may want to send the urine culture and the blood culture as well, okay. So it really depends like on case to case that what are the investigation you need to order. So you need to have all of these investigations in mind and make sure that you are ordering the correct investigation at the right level, okay. So really really important thing. Then before moving on to the D part comes your secondary assessment, and in this case, you need to reassess the airway and the breathing, and the same two parameters that needs to be checked. Like for example, the oxygen saturation and the respiratory rate, and if there is a need for any further intervention, do that. Or if there is no need for any further intervention, then you can just move on and move on to D. But as I mentioned, there is a very strong possibility if it's an asthma case or a COPD case, or a opioid poisoning case, okay. They may want to do some kind of interventions in oxygen saturation and respiratory rate. Parameters may be deranged, and you may want to do some interventions to improve that. Either change the oxygen mask, either add another bronchodilator, or escalate the care, or repeat a particular investigation, or repeat a particular intervention, okay. So make sure that you are checking the oxygen saturation and the respiratory rate again. Okay, you don't need to check the circulation part over here because you just did circulation. Okay, that was the last thing that you did. So in the reassessment 2, it's just the airway and the breathing parameters. And what are the airway and the breathing parameters? It's just the oxygen saturation and the respiratory rate that you need to assess and that you need to see. Okay, so yeah, that was till the C part. Now let's just move on to the D part. Okay, in the D part, first of all, you need to check the AVPU scale, that is the alert verbal pain unresponsive scale. Okay, or the GCS. Okay, you need to see that if the patient is conscious, if it's alert or not. And you can just comment on it that okay, my patient is alert and talking to me. Sorry, you can't say that. Okay, Mr. Adam, I can see that you are alert and you're talking to me, and you are in your complete consciousness. Let me just check your drug chart. Okay, and there is a drug chart that would be uh, present. Okay, and that would be kept over here on the emergency crash trolley. Okay, so see the drug chart, and what you can see that okay, the patient may be on blood thinner medication, the patient may have just had morphine. Okay, so you need to see that what kind of medication the patient is taking. Okay, and the cases where it is relevant is all the bleeding cases, because the patient may be on blood thinner, like for example the warfarin or the anaphylaxis case, in which the drug chart would state that okay, the patient is taking penicillin. Okay, and the patient may be allergic to penicillin, and the opioid poisoning case, in which the patient would be post-operative, and a morphine dose must have been given to the patient recently. Okay, so you need to check the drug chart, very important, after the GCS. And then you need to check the pupil reaction to light. Okay, you need to check whether the pupil are pinpoint. Okay, uh, and very important thing. So I have mentioned it over here in the D part. Okay, but uh, if when you start off with your assessment, and if in the airway part, if you find that the respiratory rate is low, and if you find that the respiratory rate is less than 10, okay, in the airway and the breathing assessment, then you need to like pick up this step and do it in the airway and the breathing part. Okay, immediately break the chain, break the cycle, and do not wait until D to check the pupillary reaction to light. Okay, you find a low respiratory rate, you immediately check the pupil in A part only. Okay, and do this step in the either A or the B section, and do not wait till D. Why? Because low respiratory rate is indicating that okay, this patient may be having opioid poisoning. Okay, and just think about it. You found a low respiratory rate in A part. Okay, and then you did not check the pupil, you did not begin your management of opioid poisoning right at the A level. Okay, and you did the airway assessment, then you did the breathing, then you did the circulation, and then you came at D, and then you checked the pupils, and then you found out that okay, the pupils are pinpoint. By the time you come to D to manage the opioid poisoning, it would be very late. Okay, so you need to break this chain only in the case when you find a low respiratory rate. Just pick up this point and check the pupil in the airway section. Okay, uh, and a lot of question comes to me that Dr. Sarosh, pupil has got nothing to do with the airway, so why are we checking it in the airway? But just think about it, what is being compromised because of opioid poisoning? The respiratory rate is being compromised. Okay, the breathing is being compromised. Okay, so it's not about the fact that whether if something is directly related to airway or breathing, but because of this, because of the opioid poisoning, the respiratory rate and the respiratory drive is being compromised. So eventually the problem is coming in the breathing part. Okay, even though it's something related to the D, the opioid poisoning, usually you check it in the D part, but it is compromising the breathing part first. Okay, so since it is compromising the breathing part first, and you need to get sure whether or not it is an opioid poisoning or not. So it automatically becomes an intervention, and it automatically becomes an assessment at that needs to be done at the airway or the breathing level. Okay, so like really important, and this is the only part, and this is the only like exemption where you are allowed to break the chain of your assessment. Okay, Other than that, you need to, very strictly and very, like, in a very straight way, follow the approach that has been taught to you. But if you find that the respiratory rate is low, okay, then in the airway and breathing assessment, break this chain, you're allowed to break this chain, and immediately check the uh, pupil reflexes over here in the A part only, okay, and then begin giving naloxone, okay, and then keep on continuing your assessment, and keep on covering your investigations and intervention like the way you have been doing it, okay. So this is something really really important that I wanted to tell you, that this is the exemption where you can break the chain, you're allowed to break the chain, okay. So really really important. Then comes the blood glucose level. That is the fourth thing that you need to check. And in the hypoglycemia case, everything, you check, would be found. You would find it to be very very normal, within the normal range. Everything, would be all right. The patient would be vitally stable, and just the patient would be unconscious. Okay, the respiratory rate would also be normal. The pupils would also be normal. Uh, the drug chart would only show that, okay, the patient is on insulin. Okay, and once you check the blood glucose level in the D part, okay, that is where you would, realize that, okay, the blood glucose is like really really low, okay. The normal is 4 millimole, okay. And once you check the blood glucose level, that, okay, Mr. Adam, let me just check your blood glucose level, and the examiner would say that blood glucose is 1 millimole, okay. You know that it is hypoglycemia, all right. And then after you're done with that, the monitor parameters, now you need to check all the monitor parameters, okay. For D, just, keep a look, and just comment on all the parameters, that, okay, I can see, Mr. Adam, that your vitals are within the normal range, and I'm happy with your heart rhythm as well, I'm happy with your oxygen saturation as well, and it's good to see that all the interventions that I've done has worked, and now your condition is vitally improving, okay. And now comes the intervention, okay. The intervention is basically mostly related to the hypoglycemia part, okay. And you need to give 50 ml of glucose, 10%, and it can be repeated 4 times, okay. So there is a very strong possibility that they may not improve the blood glucose levels, okay, until unless you repeat it 4 times, okay. So you need to, have this thing in your mind. Then there is a very strong possibility that, they may say that, okay, there is no IV access in the patient, okay. And this has happened with a lot of, hypoglycemia cases, that they said that, like, as soon as you started verbalizing that, okay, I'm going to give you glucose 10%, and that can be repeated 4 times, they're going to say the IV cannulas are blocked, the IV cannulas are not present, the veins are very very thin, there is no IV access, okay, because they want you to, verbalize that, okay, no problem, let me take out intramuscular glucagon from this drawer, okay, and then let me just give you intramuscular glucagon, okay. And then if the patient is alcoholic, you may want to give IV Pebrinex before giving the glucose. And in case of opioid poisoning, I've talked about it, that IV naloxone is given 400 microgram, 800 microgram, and then again 800 microgram. But this is something that is not, started at the D part. It is something that would be started at the airway part only. So in the A and B part, you would be giving this dose, okay. Then after the reassessment number 2, you would be giving uh, yeah, so after the reassessment part number 2, you would be giving this dose, and then after the reassessment number 4, you would be giving this dose, okay. So you need to, grade your intervention like this, okay. So I just mentioned it in the D part, just for your knowledge, but you have to begin it earlier on. Then in the investigation part, okay, you may want to send HbA1c for a hypoglycemia case for a diabetic patient, okay. And in the case of opioid poisoning, you may want to, give the serum morphine, okay. Just these two investigations are, relevant in this case, okay. And then the reassessment number 3, and in the reassessment number 3, you need to check each and everything, the airway, breathing and circulation, you need to look at the monitor again, you need to check for anything that may be wrong in either of the parameters, okay. and if there is any intervention required, do it, and if it's not required, then just move on to the E part. Okay, the E part is basically the exposure and the escalation. Okay, and in the assessment part, what you need to do is that you just need to assess the patient for any rashes, any bleeding. Okay, and you need to check the catheter as well. Okay, this is really important because in the urosepsis case, the patient may be having a urosepsis because of a dirty catheter. Okay, so in the E part, you need to check the like lower part and the front passage, and you would see a very dusky and a very dusty urine bag, and you would eventually have to verbalize that, okay, Mr. Adam, I can see that your urine line or the urine catheter is very dirty, and that may be the cause of the infection. Let me just very quickly change your urinary catheter and just send some of the samples of the urine for a urine culture. Okay, and then in case of perrectal bleeding, you may find some uh, bleeding that may be occurring from the back passage, so you need to comment on that. In case of anaphylaxis, you may just find some rashes. Okay, and you may have to comment on that. Okay, there are a few rashes at the back as well. I've given you some medication, some antihistamines for covering your rash, so you will be fine regarding that. Okay, then why I call it as the escalation as well, because you need to make the referrals, and you need to refer a few cases to a few specialities, like for example, or the circulatory cases, heart failure, atrial fibrillation, they need to be referred to the cardiologist. Postpartum hemorrhage needs to be referred to the obgyn. Anaphylaxis case, and every case in which the patient becomes like really really critical, and the airway is very very severely compromised. Okay, in cases like these, you would have to refer the patient to the intubation unit. Okay, in the case of hematemesis and gastric ulcers, you may just want to refer the patient to gastroenterologist. For the bleeding disorders and the patient who's having bleeding because of warfarin toxicity and because of blood thinner medications, hematologist may need to be involved. Then for the hypoglycemia case, endocrinologist or diabetologist may need to be involved. For post-operative pain, you may just want to involve the pain specialist. Okay, so just make sure that you are doing the right referrals in the E part, and you're doing the right exposure and any intervention that may be needed over here. Okay, so that is what the E part is. And then once you are done with that, hopefully your patient would be vitally stable, the patient would be saved, you would have done everything that is needed, and then just do a final reassessment, and eventually explain the situation to the patient, that what happened to you, and now you are fine, and not now what is going to happen. Okay, so yeah, that was what the SIMMAN approach was. That is what the SIMMAN was. Okay, and I have summarized it, that what needs to be done in the assessment of each letter, airway, breathing, circulation, and what are the monitor parameters you need to look into, what are the possible interventions that you need to do, and what are the investigation that needs to be done. So I hope that you've taken a screenshot of this, and if you have not, just take it right now, so that this entire SIMMAN approach is there in your head in a very very comprised, in a very very summarized way, and it's very easy for you to do the revision just a couple of days before the exam. Okay, so yeah, pretty long lecture. A lot of speaking was done in this, but I had to teach it in a lot of detail, because SIMMAN is one of my favorite topics to teach, and I strongly believe that the SIMMAN needs to be mastered, because again, I've seen a pattern that those students who are not clearing their SIMMAN, they're also not clearing their exam. Okay, it's just a pattern that I have noted. So you need to make sure that your SIMMAN is very very much sorted, and you are very very well versed with the SIMMAN. Okay, so that's pretty much it from my side. If you've got any queries and any questions, drop them down in the comment box below, or you can drop them down on the social media, or my social media handles. I'm going to address all your concerns over there. And if you want a personalized mock, a one-on-one mock, or and a SIMMAN mock as well. Okay, we offer SIMMAN mock as well, online SIMMAN mock. So if you want that, you can scan the QR code, and you can get the more details, and my team is going to contact you for that. And that's pretty much it from my side. See you in the next lecture.